Hello, everyone. October is Breast Cancer Awareness Month. And to get the conversation started, this presentation, what every man and woman should understand about early detection and does it really matter, has been designed to provide you with understanding related to the importance of early detection. With that being said, let's get started. This session will enable you to understand the cause or etiology, transmission, and prevalence of breast cancer in the United States. We will also talk about your risks, understanding risk factors associated with breast cancer, and also the differences between male and female breast cancer subtypes, as well as some of the ethnic differences. This session will also enable you to understand the real benefits of early detection and diagnostic services. There's so many myths out there related to early detection, but hopefully at the end of this session, you will be able to understand why diagnostic services really matter. In segment one, we will have a conversation about what is breast cancer. Many of us still don't know what breast cancer is, or some of us really don't want to understand it. We may be afraid of it. So hopefully at the end of this session, hopefully you have a better understanding of early diagnostic services and how they can save your life. Breast carcinoma or breast cancer affects three distinct areas of the breast. And this is for male and also female. The lobules of the breast, milk ducts of the breast, and the fat and connective tissues of the breast. Let's talk about transmission and how breast cancer actually starts. Let's pause for a moment and talk about transmission. In the prior slide, we talked about lobules, ducts, and the connective tissues. Well, what are lobules? Lobules are the glands that actually produce milk. The ducts filter milk to the nipple area, and the connective tissue surrounds the area of the breast. Then I have an illustration in my next slide, but I wanted to talk this through first. Now, breast cancer can also filter throughout the lymphatic system into the bloodstream and other areas of the body, such as bones or lungs. That's why diagnostic procedures are extremely important to check for suspicious lumps or abnormalities in those regions. The other thing is the prognosis is much better when diagnosed in early stages, and we will talk about that later on in the presentation. Let's take a look at the male and female anatomy of the breast. There are some similarities and some differences. For example, both men and women have ducts, they have milk ducts. There's fatty tissue, they both have lymph nodes or lymphatic system, and nipples. Now, what's more pronounced in the female is the lobules. The breast cancer can be diagnosed in the lobules there. However, where men are concerned, breast cancer is more commonly diagnosed in the duct area. Classifications. Breast cancer falls into four distinct classifications. In situ, and that's where breast cancer has not grown outside of the breast tissue area. They're localized, could be lumps confined to just one area of the breast. Invasive or infiltrating is breast cancer that has spread beyond the ducts, beyond the lobules. It could be in the connective tissue. And then distant or metastatic breast cancer has spread beyond those other parts of the breast into other parts of the body. For example, breast cancer in stage 4 could be in the bones, the lungs, the liver, and also the brain. And then we also have a category that's unknown, and we really don't have a thorough understanding of that advanced type of breast cancer. Let's take a look at the types of both male and female breast cancers that have been diagnosed by pathologists. Ductal carcinoma in situ, lobular carcinoma in situ. And remember when we talked about the ducts, the lobules, and the connective tissues? They're similar named based on where the disease is located at. So in situ meaning it being confined to the ducts or the lobules. Invasive lobular carcinoma and invasive ductal carcinoma, which is most common in men, that's when it is spread outside of those areas. Then we have inflammatory breast cancer that is very aggressive. Paget's disease of the breast is rare. It affects the area of the nipple. Then recurrent breast cancer that continues to come back despite treatment, and angiosarcoma affects the blood vessels. And most of the time, this is when a male or female would have prior radiation related to a breast cancer. And then benign breast disease is it's a disease where there's tumors in the breast, but it's benign, it's non-cancerous. Let's talk a little bit about the measurements for breast cancer. A breast cancer has been known to be high or be positive for estrogen, progesterone, and something we call the HER2 neuron. HER2 means human epidermal growth factor receptor 2. There is a gene that produces HER2. It's called ERBB2. So it produces the protein. So most cases of breast cancer are high or positive for those three things. But what we found out in the last decade, which I did my research on, is triple negative breast cancer. And this is breast cancer that's absent of these three biomarkers or negative of estrogen, progesterone, and HER2. So it doesn't mean negative like something is fundamentally negative. It means it does not have any of those higher levels of estrogen, progesterone, or HER2 neuron in order to spread or grow. And we'll talk about that later on. In the previous slide, we talked about the biomarkers for breast cancer being estrogen, progesterone, and the HER2 neuron or protein. And so, in terms of the subtypes, let's take a look at the prevalence and what racial and ethnic groups are most risk. Positive types of breast cancer are more at risk among white or Caucasian women at 73%. They're diagnosed. They're lower in Black women or African American women at 59%, and triple negative breast cancers are higher among Black women at 1 to 5% of the cases versus 1 to 10 in other racial and ethnic groups. And then you also have this negative hormone receptor, but a positive of the HER2 neuron subtype that's very rare in 3 to 6% of the cases. What does this mean? In the previous slide, we discussed the distinct types or subtypes of breast cancer. When you have a positive form, it's slower in growth. It has better prognosis from what the research has stated. The negative ones have a tendency to be more aggressive, fast growing, and of course, triple negative is more likely to be diagnosed in the later stage. So that's another reason why early detection matters. Let's take a look at the symptoms. Not all symptoms are visible or obvious. Some symptoms are, as we call it, asymptomatic. There are no signs, and that's why early detection is very important, such as lumps in the breast or the armpit, or changes in the breast shape, or a rash, or inverted nipple, or breast dimpling, or skin texture changes. These are the symptoms that have been most commonly found. However, again, a person could be asymptomatic. In segment 2, we will have a conversation about what factors have been linked to breast cancer. It's very important for you to understand the causes and the etiology. So let's get started. Let's discuss breast cancer etiology or the causes or factors associated with breast cancer. First thing you need to know is genetics only accounts for 5 to 10% of all breast cancers. So if you have a first degree relative with breast cancer, or you had a parent with breast cancer, and if they have the mutations, you have a 50% risk of passing it on to your children, and someone up to like maybe a 45% chance of developing breast cancer over a lifetime. Those are things you can't prevent. However, there are areas that you can prevent, such as alcohol consumption, obesity, hormonal therapy, hormonal contraceptive use, type 2 diabetes, which is a disorder, weight gain, physical inactivity, and breast density. They say that because the thicker the breast, it's very difficult for, at times, for the diagnostic services to really be able to see the breast cancer. So, those are some of the kinds of things that we look at that are not preventable and some things that are preventable. What factors do not contribute to breast cancer? There are several myths that have been associated with the cause of breast cancer. For example, wearing a bra has been one, breast implants has been another, although implants can obstruct the diagnostic process, and also abortion. So, those factors have no correlation with breast cancer at all. Now, think about it. Men do not wear bras, and neither do men get abortions, and they can still get breast cancer. So, with that being said, those following things are not related to breast cancer. And you can see that in the comparison between male and female and how breast cancer occurs. In segment 3, we will have a conversation about the prevalence of female and male breast cancer in the United States, as well as some of the ethnic differences. So let's get started. Let's take a look at breast cancer incidence among women. If you look at this slide, you will see that breast cancer incidence is highest among white women and lower among Hispanic women. But one of the things that we really want to pinpoint in this slide is that breast cancer incidence has increased during the last decade by 1%, and it also has increased in women under the age of 50 at 1.4%. We'll discuss this later in our series. Breast cancer incidence in men. From this slide, you can see that men do get breast cancer. In 2024, 2,790 men were projected to be diagnosed with breast cancer, among which 530 men were said to die. Most of breast cancer in men, it is diagnosed in an advanced or later stage in comparison to women due to the lack of screening and lack of awareness. There's also a 5-year survival rate, which is lower than women at 84 versus 91%. But we can change that through awareness and through better diagnostic services and screening. Male breast cancer incidence and mortality rates. If you take a look at the bar chart that is provided, you will see the incidence rates from 2017 to 2021, and you will see the mortality rates that go up to 2020. And if you notice that male bar is 1.9 per 100,000 men, and they're black men. So black men have the highest rate of terms of incidence and also the highest mortality. We talk a little bit about the screening. And then what's interesting is that your Hispanic, your Asian American, and your American Indian, they all have the same level of prevalence, whereas your white is at 1.3. So you can look at the mortality rates. Again, a lot of this has to do with diagnostic, and a lot of times men are just not aware that they can also get breast cancer. In this slide, we will compare male versus female incidence and mortality rates. So men are more likely to be diagnosed in advanced stages. And if you look at the bar chart and the first bar is male, you will look at the black area where it says distance and unstage. That's higher for male as opposed to female. And then the next chart in terms of mortality rate, mortality prognosis among the female is higher, is 91%. And 84% in the male. And then when you look at the localized It's almost a 99% of a survival when you catch it early, and that's a critical. And it's in the 90s for men as well. And then if you look at the distant stage and the unstage, you can see where it's a higher rate of survival for females than it is for the males. So if you see the 70 at the last bar chart and the 62 for men. Let's take a look at breast cancer mortality rates. And it's critical to understand that although breast cancer incidence rates are higher in white women, mortality rates are higher in African American women and American Indian Alaskan Native women. If you look at the orange and the darker mauve box, you can see the prevalence there. Asian women have the lower incidence of mortality. So it's very critical to target resources to all women, but really targeting African American women and American Indian women are critical because we see the highest levels of mortality. Let's have a conversation about breast cancer incidence in young women. What we see is breast cancer is on the rise in young women. There were over 300,000 cases of invasive breast cancer diagnosed. And those are cancers that have poor prognosis. Black women had the highest incidence under age 40, and the data shows that invasive breast cancer incidence has increased by 1% each year. So we have to be really, really mindful of providing resources to young women that don't realize that, oh, yes, you can also get breast cancer. And the data actually shows a lower incidence in women 50 and over in comparison to younger women under the age of 50. The critical question is, do young women want to find out about preventative services? Well, the answer is yes. I conducted applied research intervention study and I found out that women under the age of 40 wanted to avail themselves. Some of them had parents that had died from breast cancer. There was hereditary forms of breast cancer. And so we know that the phenomenon is largely unexplained. However, it does happen. I want to go to the next slide so you can see the prevalence of breast cancer in women under the age of 40 and under the age of 49. Let's take a look at the incidence of breast cancer among young women. If you look at this slide, for women under the age of 40, over 13,000 cases were diagnosed in 2024. And under the age of 49, over 37,000 cases. And the cases are invasive. They're not highly in situ where the breast cancer is confined to the lobules of the ducts. It is spread beyond, which means a poor prognosis. So it's very important for us to get those resources to young women prior to age 40 and throughout 40 to 49. So let's keep this conversation going. The U.S. Preventative Services Task Force issued guidance that now women beginning at age 40 can avail themselves to a mammogram. But we still have some problems. Low screening is among women age 40 and 44, American Indian, Alaskan Native women, those who do not have a high school education, uninsured, and immigrated in the past 10 years. And although Black women have the highest screening prevalence, quality of care has created issues related to mortality. So let's keep this conversation going because it is real and early detection matters. To continue the conversation, breast cancer screening has improved over the years. Now we have mammograms that have 3D digital imaging, MRIs, ultrasound, and PET scan is used when the cancer has spread to the bones, the liver, or the brain. So there's various screening methodologies that can be used to detect breast cancer. This is important because once it's detected, it can be treated. In my final conversation, and in a nutshell, what do we know? We know that breast cancer mortality rates have decreased. about 44%. We also know in terms of a 5-year relative survival rate, it's a 99% chance of living when breast cancer is found in the earliest stages in comparison to when it's found in the later or distant stage at 32%. We also know that there is a difference between men and women. Men have an 84% chance of a 5-year survival in comparison to women with a 91%. So, with that being said, we know that early diagnostics work, but you have to do the work. It's up to you to avail yourself to the resources that are out there. And in the final conversation, I'm Dr. Michelle Dowdy, and I hope you got something out of this presentation today. Some of the resources that I've used from American Cancer Society, I'm using my applied research intervention study. You'll be hearing more about that. The National Institutes for Health and Memorial Sloan Kettering has some male resources. I would encourage you to think about early detection in a different light, and I hope I've been able to do that. Thank you, everyone, and have a great day.